Hi everyone. So we might get started again. Hopefully you've all had a chance to grab a drink and sit back down. So I'd like to introduce Maddie, who's joined us from MIPS, who's we're really lucky to have sponsoring our conference today, and who's contributed significantly to all of the conference bags that will be coming to you, and the packs. So Maddie will be talking to us about MIPS and about what they can offer.
Thanks so much, Maddie, and thank you so much for having me. I hope it's been a fantastic morning so far from what I've been able to sit in on. It's been brilliant. I know you've probably always had somebody come and talk to you either at your hospital space or at university, and so I don't really want to talk at anybody today. I would love to see, what is it if I say, what is the first word that comes to your mind when you hear the word MIPS? If I could request you to put something in the chat, I'd love to talk about it that way rather than actually talk at you about indemnity, because I know we've all heard about indemnity, but what is it that's really different with us? Or what do you think when you think about MIPS? I'll give you a minute to put something in the chat. I hope somebody does put something in the chat, otherwise it feels like I'm just talking to myself. But also what I'm going to do is I'm going to put in a link in the chat. If I could request you to please click on it and complete the form either during the course of the day, just so we could really be able to provide you with information that you actually would like to hear from us about. So I'll put that into the chat link now. Please let me know if you can not see it. Nobody wants to put anything about MIPS in the chat though. MIPS pens, yes. So I do get told a lot, especially when I'm at hospitals, that they love our pens. They do seem to write really well. So we will make sure we always have the pens for you. It's just another level of support that we offer in terms of if you are, just in a situation at a hospital or even at university, and you're just feeling that a bit overwhelmed or feel something just hasn't gone right, it's got a 1-800 number on it. So please always use that. We are available for you 24/7. We either have a medical advisor who's available to talk to you till 6 p.m. or if you do call after hours, there is a legal advisor available to give you some information, or if you do still need to speak to a medical advisor after hours, one can be provided for you. MIPS water bottles, how cool were they when you guys all just started and those were the only glass ones you could actually take into exams? And initially it was always like, why am I signing up to all of these people and why am I getting a MIPS water bottle? But I do hope that it was again a reminder that you've got someone in your corner, even while you're at university or going away to doing your electives cover, that you are covered for things that you may not have access to while at university. Complimentary cover for junior doctors, and we still do offer that. Thanks, Katie. So while you are a intern and resident, as well as a postgraduate year 3, your membership fee is actually waived. So you only start to pay for MIPS indemnity cover at postgraduate year 4. So for anybody here who is currently at the PGY stage 4 level and thinking about where they want to go or why they should go with MIPS, please do click on the link that I have put in, complete the form, and I'll be able to send you some information. Again, all indemnity covers, all indemnity providers do offer you the same thing in terms of $20 million in cover, but we do it quite differently. At MIPS, you're actually covered for no sublimits, which means if you do have to go to court or legal representation is sought, you are actually not out of pocket at all. It's all covered for you. As I mentioned earlier, you do have the 24/7 clinical legal helpline available to you. We also have our on access and on-demand education available, which has a plethora of webinars available, from dealing with patients, difficult patients, to having difficult conversations with colleagues, to mandatory reporting if you need to report yourself or a colleague to APRA. So you can always have a look there. Somebody did actually mention locuming as well in one of the previous presentations. And I'm not sure if you're aware, but if you're locuming, MIPS actually will cover you for your locuming practice as well, as long as you let us know how long you're doing it for and whether it's supervised or not. At the end of the day, you want an indemnity partner who is there with you and shows up for you to help protect the career that you work so hard to build, to protect the reputation that you've built, and to continue to protect your livelihood. So thank you so much for having me. I hope the rest of the day is fantastic. And please do click on the link, because that just allows us to continue to ensure that we are giving you the correct information. We are actually offering the right webinars that our doctors require, and it also continues to allow us to sponsor events like this. So thank you so much for having me.
Thank you so much again, Maddie, and thank you for all of MIP's support today. It's been
Cheers.
brilliant. Thanks. So I'll move on to introduce our next speaker. So it's my pleasure to introduce Professor Michael Permezel to share with us his wisdom and also a comprehensive overview of admission into the RANZCOG training program. So Professor Permezel has had a long and illustrious career, largely based at Mercy Hospital for Women and also at the University of Melbourne, where he's been bestowed the Emeritus Professor of Obstetrics and Gynecology for his contributions in women's health, medical education and research. He's a past president of RANZCOG and last year retired from the University of Melbourne and Mercy Hospital for Women to become the Dean of Education at RANZCOG. So he's an absolutely highly qualified person to be speaking on this topic, and we're really honoured to have him today. So please give him a warm welcome.
Good morning. Thank you for asking me to give this talk on selection for RANZCOG training. So we'll begin with what's the object of the selection process. Well, what the college is trying to do is choose the best workforce that is most able to deliver excellence in women's health. That means we need diversity as well as quality. What do I mean by diversity? Well, we need to meet the general needs, the general obstetrician gynecologist in the large cities of Australia and New Zealand, but also there are specific needs that need to be met: rural, Indigenous, academic, global women's health. So this is where you can find out all the information that I'll give you today. There's an excellent website entitled Applying for RANZCOG Training, and you can get to that website simply by Googling Applying for RANZCOG Training, and it's really very comprehensive and very good. So I'll work through each of the areas that are important in selection for RANZCOG training, just to give you a bit of an overview, but I would urge you to go to that website to get more detail. So essentially, in any job application, anywhere for anything, there are three things that can be looked at: curriculum vitae, what you've done up until now; references, what people think of you; and the interview. And in the case of selection for RANZCOG training, there are two sorts of references. There are the referees you nominate yourself, and then there's the hospital reference. And you can see there alongside of the relative values and the interview, the biggest single determinant, an applicant nominated, worth slightly less than the others because it's found not to correlate quite as well or discriminate as much as the other factors. Okay, curriculum vitae, what's looked at? There are essentially 6 areas that score points: clinical experience, academic, research, courses in the pre-vocational program, rurality and Indigenous status, and leadership and altruism. Why do we have these? Well, some are inherent qualities like leadership and altruism. Others identify a specific workforce need: academic, rurality, and Indigenous. And thirdly, we want to incentivize certain behaviours prior to entering RANZCOG training. It's valuable having some clinical experience in O&G. Undoubtedly, it's helpful to have done some courses in the pre-vocational program, and it's good to have done some research. Unlike other colleges, we're not insisting on huge volumes of research, but there are points for those that have managed to do a few presentations or got a couple of publications. Okay, how does the clinical experience work? Well, firstly, clinical experience is worth quite a lot of points. So experience in O&G every 6 months up to 2 years is worth 3 points, so you can gain a total of 12 points. But as highlighted a couple of lines down, if 12 of those months is rural, there's an additional 3 points. So potentially up to 15 points for experience in O&G, whereas experience in non-O&G gathers only up to 3 points, 2 points for 12 months and 3 points for 24. This experience must be in blocks of 6 months, so short locums won't count. Academic can score up to 8 points in one section of high achievements like first place in the medical course or first place in O&G, gain substantive points, but there are other academic achievements that are awarded up to 3. Research, hardly anyone has a PhD and not relevant. I think there's only 1 or 2 people with a PhD every second or third year, so it's uncommon. First author publications are awarded 1 point, but only to a maximum of 2 points, and presentations 0.5 points, again to a maximum of 2 points. Rurality earns a maximum of 5 points, and what earns rural points? Well, the most common one is to be rurally resident during secondary schooling. But there are other ways to get rural points, such as in a non-bonded place in a rural clinical school. Indigenous status is awarded 10 points because of the obvious particular need for O&G specialists in that area. The pre-vocational programs awarded 5 points. It is surprising that there are some applicants who are disappointed at not getting into RANZCOG training and yet haven't done the PVP. Other courses are worth up to 3 points. Altruism and leadership are worth 5 and 6 points respectively. As you might expect, the high points are for the high achievers, things like terms with Medicine Sans Frontières or Rhodes Scholarship or similar activities, but also lesser activities earn smaller numbers of points, such as participation in a soup kitchen or other similar activity assisting with the disadvantaged. References. References are of 2 sorts, applicant nominated and hospital references. The applicant nominated references, there are 4 applicant nominated references and 16 questions. The questions cover areas like communication, knowledge, clinical skills, diligence, teaching, educational activities, and so on. The referees have simple descriptors and a narrow range to fill in: below expectations, at expectations, and above expectations. And these scores correlate well with the overall outcome, but they're not great discriminators. Most applicants score well on their applicant-nominated referees. Hospital references, on the other hand, contribute a bit more, or twice as much, to the final score, 24% instead of 12%, and they do discriminate between applicants. Why do we have hospital reference? Because we believe, in fact, have shown that performance as a pre-vocational trainee is very likely to be the best predictor of future performance as a RANZCOG trainee. It makes sense, and we've shown it to be true. The hospital reference enables pre-vocational performance to input effectively into the selection process. It assesses many clinical and professional qualities critical to working in women's health. Again, things like diligence, clinical ability, surgical skills, communication skills, all very, very important in the future O&G specialist, and highlighted in references much more so than curriculum vitae or references. Or who does the scoring? Well, the scoring for the hospital references is coordinated by the training supervisor, following feedback from a panel of consultants and registrars. What counts are 6-month blocks in O&G. Small locums don't count, and the blocks in O&G have to occur since the 1st of January the year prior. So for this current year, selection took place in August, September, so the blocks of O&G had to occur since the 1st of January 2020. And if there's more than one hospital, then the score from each relevant hospital is averaged. There are a small number of trainees, usually just a handful, 4 or 5 out of the 200, that don't have a valid hospital reference because they've only worked at small hospitals. And for those trainees, they are awarded a hospital reference that retains their position in the overall rank. So they're neither advantaged nor disadvantaged by not having a hospital reference. The interview consists of 6 structured questions. The total interview is 15 minutes, and little or no O&G knowledge is needed. The score is out of 37. There's an easy first question to settle with 2 marks, a subsequent 5 questions with 5 marks each, and an overall global score worth 10 marks. A couple of issues. Obviously, interviews will favour the confident and penalise the shy. So we're happy that the interview contributes, but we don't want it to be the single determinant for selection, as can easily take place if all other things are scoring the same. There are many examples of outstanding introverts who don't interview all that well, the quiet achiever. And there are also many examples of non-outstanding extroverts, people who interview well but don't actually perform that well on the job. And there are a couple of examples. Which one would you want on the training program? So will you get into RANZCOG training? Well, Australia has about 85 places for 200 applicants, and New Zealand about 18 for 30 applicants. They're separate selection processes. It's an unfortunate reality that many outstanding applicants will miss out. What if I don't get into RANZCOG training? Well, firstly, realistically appraise the likelihood of future success. There are key discriminators like clinical experience points. Did you max out at 12, 15 or whatever? Or is there an opportunity to get further points by further clinical experience? Hospital reference is very important in selection. It's a key discriminator. Is it likely to improve? Are you staying at the same hospital and therefore likely to retain a similar hospital reference? Not definitely, but likely to. Or are you moving to another hospital? If you are, will the previous hospital reference count, i.e. will it have occurred in the 18 months prior to selection? And then interview performance. How did you feel that you interviewed? You'll get feedback on the interview from the college. So that'll help guide whether or not that's an area where you could. And you have to realistically consider alternative in women's health. There are many GPs practice with a diploma advanced totally in women's health and have an excellent career. Global women's health, sexual health physicians, these are all alternatives other than RANZCOG training that offer excellent careers in women's health. So that's all. Thank you. And I'm hoping to be around to answer some questions. Thanks.
Thank you so much, Prof. Thank you so much, Prof. Permezel, for joining us and for that awesome talk. Everyone always has so many questions about entry to the program, and
why would that be?
Yes, I know it appears a very confusing process. So we're always so keen to have people wonderfully like yourself to give us some tips and tricks. We do have a few questions, if that's okay.
No worries. Well, I've got a couple online here. Do you want me to tackle those first?
Yeah, I'll shoot those through and you can answer. So we've got.
Well, I can see the question
perfect.
and answers. Yeah.
Awesome.
Thank you. The first one is, can an applicant who's only worked in Australia apply to work in New Zealand and vice versa? Yes, but at the moment, their New Zealand selection occurs before Australia, so you can't do both. You've got to decide which one you want. There are some talk in the college that the two processes should be combined. New Zealand is very different in lots of ways, and their selection is slightly different. So at the moment you have to decide. Of course, if you're in Australia, you can apply in New Zealand, but both countries have a requirement that you must have permanent residency. So it's it'd be relatively unlikely that someone who's only worked in Australia has permanent residency in New Zealand, but possible, i.e. someone who grew up in New Zealand and was educated in Australia, and vice versa. But PR is a requirement. So I think that answers that one, so you definitely can. Would they be biased in favour of their own if you walked in with an Australian accent? Well, I wouldn't want to say New Zealand was a bit parochial and like their own, so I won't comment further on that. Can we get an indication of what number of CV points would be likely to get in an interview and likely to get into training? The answer is people generally score very similarly on CV points. I tried to make that clear in the little presentation. There isn't a lot of discretion. I'm just going from memory, but you know, if you looked at the 90th centile and the 10th centile for CV points, you know, it would be something like 8 and 12 out of 100. You know, like there might be 4 between the 10th centile and the 90th centile on CV, because most people have got experience. You're crazy, as I said, I didn't use the word crazy in my little talk, but I can use it now. Crazy if you don't do the PVP. There's 5 points just waiting there for you to pick up off the ground. It's just you're walking along and they're lying on the footpath, pick them up. They're worth something, but most people have done the PVP. Most people have got the 12 points for O&G experience, you know, maybe the 3 for rural or not. You've got to look at your personal circumstance, whether it's worth doing those extra 3. So there isn't a lot of discretion in the CV. What really counts in terms of shortlisting is the references, and references are the things that will definitely get you an interview. But for the last 2 years, we've managed to interview all 200 applicants. Now, that's not necessarily going to be in the future. It is hard getting through 200, and we sort of just achieved it this year. If we had 220, excellent attendance, Samantha, so congratulations to the organisers on what you've done. If we have more than 200, I think there will be shortlisting, but the key discriminator in the shortlisting will be your references, not so much a CV. What makes you give a junior doctor an excellent reference? Well, this is very Permezel, and there are a couple of things. One is, as we said, the hospital reference has to be a collective, so involving registrars and the consultants at the hospital. It's not just one person's view, but the Permezel view is the emphasis on the registrars and your colleague residents. The people that you're around, they know you a whole lot better than consultants. So if you're somebody who helps out the other doctors, doesn't disappear with a poor handover, you know, all the usual things that you know, they're the people that are going to score well. The person that's absolutely charming to the consultants, but not terribly charming to their colleague residents, they're the ones that aren't going to score well. There are some people who can't believe their reference wasn't superb when all the consultants loved them, but they were very competitive with their colleague residents and registrars and didn't treat them that well. And they end up with a poor reference. They can't believe it because they were so nice to their consultants. Okay, if an applicant has done 12 months of part-time ING job share, does that count as 12 months? No, 6, yeah. Obviously, everything is pro rata. So we're the best college for a few things, but one of them is fractional training and extended leave of absence, being 85% female. We have to be very flexible in our training. So we have excellent pro rata fractional training and programs for extended leave of absence, counting training in small lots and all that sort of stuff. And that applies to selection as well. So if you do 12 months at 0.5 EFT, then that's going to count as 6 months. And everything else pro rata, although blocks of less than 6 months won't count, of course, as I said in the talk. We miss a whole year if we are unable to give the CWH exam, for example, for the 5 points. Are the CWH exams going to be more frequent? Look, I have to take that on notice. I don't know the plan. Clearly, COVID has been very difficult, and we're trying to have in general, the college is trying not to disadvantage people. But I guess there could have been a few people going for selection who did CWH pre-COVID and are struggling to sit the exam just now. So I'll have to take that on notice. And maybe, Samantha, there might be some way we can circulate an answer to that one.
Yep.
I don't know the schedule for CWH exams.
Yep.
The PVP, yeah, look, the PVP's a collection of modules online, the Fetal Surveillance Education Program, Certificate of Women's Health, and that collective earns you a whole heap of points. So it's absolutely worth doing. All the information's on the college website, and you should look at it, not just listen to me or hear it in a lecture. You should actually go to that website. And the introduction said that the selection process is confusing. Well, it is a bit. It's complex because we're trying to get the absolute best workforce for the women of Australia and New Zealand. So we do need to go into a whole lot of weird and wonderful avenues like rurality and academic performance and all sorts of things, research. There's so many things in it. So it will be of necessity complex, but it is very clearly laid out on that website. You know, every point is described, how you get them, etc. Similar to that, can you apply to do training in a different state? Yes, e.g. live and work in Queensland, but want to complete training in Tasmania. I can't imagine why you wouldn't all want to work in Victoria, but our answer is, yeah, of course you can work in another state and then apply for work for training in a state in which you haven't been living. The way it currently works, and I would expect to work at least in the coming year, is that you will be interviewed in the state for which you have applied first. So if you're living in Queensland and you decide you want to move to New South Wales and you put down New South Wales as your first choice, so even though you've worked all your life in Queensland, you will be interviewed by the New South Wales panel. That's so the hospitals in New South Wales can check you out. Remember that the college is not the employer, it's the hospitals the employer, and we feel like we've got to give them a fair go in this whole process. They want to be involved, so they're on the interview panels, but they also want to see people who are likely to come and work in their state so that they can have some idea as to whether they might like them to work at their hospital. So you will be interviewed in the state that you prioritise first. And I think there's no disadvantage or advantage in that. Good. Is the interview for the provincial training the same or different? Yeah, the provincial training program is currently interviewed in the same interview, and there's often a rural type question, which makes them feel a bit better. I think the whole thing about the provincial training program, so there are 3 currently in operation, Bendigo, Orange and Dubbo. You should only apply for those if you really want to train rurally. Remember, it's a 4-year ITP, Integrated Training Program for Basic Training. You'll spend 3 years in that rural centre. The worst thing in the world is to apply for Orange or something just as a backup because you really wanted to be in Sydney, but you thought you'd put down Orange just to increase the likelihood of you getting in. That doesn't actually increase the likelihood of you getting in. Essentially, if you're in the top 85 places, if there are 85, you're going to get in. And if you put down Orange, then you'll get Orange and you won't get Sydney. Even if you're number 1 in Australia in the whole selection, you're 1 out of 200. If you put down Orange and Sydney, Orange for phase 1 and Sydney for phase 2, but if Orange is down, phase 1 goes first, remember, or you should, hopefully you'll know. So if you put down Orange, you'll get Orange, even though you're the best person in Australia and you really wanted to be in Sydney. So only put down those phase 2 places if that's where you want to be. In practice, I can see how you might think it would increase your chances of getting in, but it doesn't. There'll be other people in the top 85 that have put down Orange. There are plenty of people that want to go rurally. So we don't go down to 88 or 90 or 95 to try and get someone to go to Orange. No, the Orange will be filled by someone in the top 85, as will Dubbo and Bendigo and Tasmania, Newcastle, ACT. So only put those places down if you really, really want to go there. And remember, you'll be sent there and you can't swap out of it. There's no, I really wanted to be in Sydney, but I put down Orange or I put down Newcastle. So after 1 year, I'm going to move to Sydney. No, you'll be there for 4 years, or rather 3 out of the first 4, you'll be able to rotate out for 12 months. Okay, should we do a diploma at RANZCOG in our RMO year? What are the benefits? Yeah, so my view is yes. That's not universally held. There's a bunch of GPs who think that the diploma and RANZCOG should not be, RANZCOG Advanced should not be for people intending on RANZCOG training. They should be for GPs, and those intending on a RANZCOG career shouldn't be using up diploma and RANZCOG posts. That's not my view. I think that, with only 85 out of 200 getting in, and presumably all of the 200 applicants interested in women's health, then getting the RANZCOG out of the way in that first year as a resident will actually put something in the locker that you've got forevermore if you don't get into RANZCOG training, and also it will help you. It will help you in RANZCOG training if you do get in, and of course the CWH component counts towards the PVP. So yes, I would recommend doing the diploma in RANZCOG if you get the chance. Can the RANZCOG Advanced be commenced as an RMO? Yes, a lot of people have done a bit of resident work before they take on the RANZCOG Advanced. Remember that most RANZCOG Advanced people will be GP trainees. So my answer to the previous question, I was really recommending the RANZCOG, not the RANZCOG Advanced. Most, but not all RANZCOG Advanced positions are in rural centres designed for GPs who are going to practice obstetrics rurally. And that's not a common prerequisite for RANZCOG training, but doing a 6-month diploma, absolutely. Do hospitals and practices advertise CWH positions to complete this before applying for the PVP? No, you get your CWH. I don't believe that. So I think you'll get the CWH information from the college website. But in general, if you're doing a resident O&G position, and nearly everybody has to do 2 years because you want that 12 points, if you're doing any of those resident positions, then you're eligible for the CWH, which is, as you know, is just currently just a simple 50-question MCQ and a few other tasks for you to do. So CWH is a no-brainer, very simple, and everybody should do it who's applying and go on and complete the PVP. Who decides how many points are awarded for the final section? The altruism and leadership 11 points. Good question. So that's very controversial. There are guidelines. The answer is that the selection committee go through all the applications. 2 people mark them, and if there's a discrepancy of more than 2, then a 3rd person judges. And there's just a small number where there's been some disagreement. But so it's very fair. There's a clear marking guideline for the selection committee going through the applications. And the truth is that most people end up with 1 or 2 points. A few get 3, no one gets 11. I've never seen anyone get more than about 5. You know, we had one Rhodes Scholar about 10 years ago. I don't think we've had one since. You know, somebody who's done 12 months with Medicine Sans Frontières, I think that was about 15 years ago. So those are the sorts of things that will get you a large number of points, but no one does. And it doesn't matter to you lot. If no one's getting the points, then it's not really out of 11, it's out of 3, because if that's the highest score anyone's going to get. So you just want to dot the I's and cross the T's and make sure that you have done something in the altruism area. It's a bit hard to do stuff in the leadership area. I think most people don't get any leadership points. It's extraordinary. You know, it's things like we had a Fulbright scholar only about 8 years ago. Yeah, those sorts of things are very uncommon. Would you recommend us doing medical students to get started? Us doing as, I don't understand that question, Samantha. Can you interpret that? What do you reckon us doing as medicals? Oh, what do you reckon? I don't think there's a lot to do at medical student level. The main thing is to find out whether you really like it. If you've done your term in O&G, then you'll have some idea. But I think you really do want to experience O&G and get right into it during the term. See how you get on with the midwives. You know, there's a whole lot of stuff you've got to learn as a medical student to find out whether or not it's an appropriate career for you. It can sound very attractive, but the reality on the ground, it's pretty hard on the factory floor. It's great, and I would recommend it to everybody, mainly because of the diversity it gives you, you know, sort of the combined medicine, surgery, young patients, most important time in their lives, all that sort of stuff, complex counselling, very heavy on communication skills. There's so many good things about O&G, but it is pretty tough on the ground in labour ward. And I think it's good to experience as much of that as you can as a medical student to work out whether it's right for you. There are a whole lot of brilliantly clever people, great communicators, perfect for O&G, who just find it's too hot in the kitchen. And you've got to have a pretty strong nerve for O&G. What state is more difficult to get into? The answer to that is probably there isn't one really, but Queensland, for some reason I don't know, has more applicants per position than the other states. Now, why that is, I think, you know, there are some great role models in Queensland, and everybody wants to do O&G in Queensland. Maybe surgery and medicine are terrible in Queensland, and everyone decides to do O&G. But there has been a bit of a drift of some people who applied in Queensland might end up getting matched to their second preference, usually New South Wales, sometimes Victoria, because there are just more applicants in Queensland than there are in other states. But everywhere is roughly, when I'm saying more, it might be one or two more. And it does make you less likely to get in. Absolutely not, because if you applied for Queensland and Queensland's oversubscribed, but you're still in the top 85, then you get sent to your second choice, New South Wales. Don't put down New South Wales to make it more likely for you to get in when you really want to be in Queensland. It doesn't work like that. If you're in the top 85, you're in. And if you're the top 18 or whatever Queensland are taking, then you'll get Queensland. If you're number 19 and you're in the top 85, then you get your second choice, which is New South Wales, presumably. One last question. We've been hearing that you should apply to the training after 1 to 2 years as an unaccredited trainee. Does that impact on selection? Yeah, well, as I said in the talk, you get 12 points for 2 years in O&G as a non-accredited resident. That's because you need to know about O&G. You need to be able to hit the training program running. You absolutely have to have some O&G experience. Next is, how can we best prepare for the interviews? What sort of questions are asked? Yeah, good question. The answer is a little panel of which I'm not a part anymore. A panel of only 3, so it's very confidential and secret. The 3 people come up with the questions, and they come up with the best possible questions they can. They tend to be paraclinical. Yeah, I'm trying to think of an example, but you know, what strategies do you think might help improve the rural workforce? You know, for example, in O&G, in women's health. You know, so you don't need to, for that sort of question, you don't need to know O&G knowledge, but you need to have been around the traps a bit and have thought of these things. The best thing you can do to prepare for the interview is to speak to people who have done the interview in past years. Presumably there are banks of interview questions around. I haven't seen any, but I bet you some of you have them. And it's really, you'd be very unwise not to try and get a look at some of the past questions, and absolutely speak to people who applied last year and the year before, and get a little group of you to up your interview skills. And is this the last question? What's your opinion on doing Masters of Women's Health or Reproductive Health or a similar master's degrees? I don't believe they currently accrue points, and I can't see how they're going to help you. Their selection for subspecialty training, if you happen to get into RANZCOG and you do your 5 years of training, you know, it is possible that a Masters of Reproductive Health, somebody on a reproductive endocrinology and infertility selection committee when you're in 5th year of training might look at your Masters of Reproductive Health, but no one else is. And I'm pretty sure, I can't see in what area you would get points in for RANZCOG training by virtue of that. So no, I wouldn't do that. I think the best thing you can do if you really want to get in, the best thing you can do is to be a really nice person around the hospital, particularly nice to your colleague residents and registrars, but also the midwives. Certainly when I was doing the points at the Mercy, I noticed we're a bit Mercy based here. Who's responsible for that?
Our IT officer.
Yeah, well, good honour. When I was doing the points at the Mercy, the midwife who'd been working with the residents, 2 of them, the one in labour ward and the one in the emergency department, would come, and I wouldn't have to ask, they'd come and tell me who we should be giving points to, who were the ones that worked well, got on with the midwives, the patients liked, and who was difficult, difficult with the midwives, difficult with the nurses, and you know, the patients had difficulty with them. So the best thing you can get to be selected, because references are such a discriminator, the best thing you can do is make a really good impression to everybody at your hospital.
Thank you so much, Prof. Permezel. That was like
no worries.
Scattergun, that was
So,
amazing. You answered everyone's questions. Thank you so much.
Well, that's lucky. Now, I just want to direct you all to the website. It's really important that you all keep up to date. I put that up as one of the slides. Presumably they have access to the slides, do they, Samantha?
Yeah.
So just make absolutely sure you got no excuse for not knowing everything on that website backwards.
That's absolutely true. Thank you so much for your time. We're so grateful.
No worries. Good. Thank you.
Have a nice afternoon.
Enjoy your day.
Thank you. Now, guys, the next thing we're going to do is have another video from our sponsors at Besson's. It's a lovely video, so we'll play that now.
Let's get started. My presentation is called New Directions in Oral Contraception. These are my disclosures. And I thought we should start before moving forward by looking back. And this slide highlights what has happened in the world of oral contraception in Australia. The pill, the combined oral contraceptive pill, came to us in about 1961, and we were amongst the first in the world to get it. The progestogen-only mini pill came in the early 1970s. The combined estrogen and progestogen pill has proved to be a highly effective contraceptive. It's the most popular form of contraception in Australia. Over the years, the pill has changed in certain ways and acquired additional, if you like, non-contraceptive benefits. But its biggest strength in many ways is that it has a 24-hour missed pill window. So if you forget for a few hours, you don't have to go through the ritual of 7 days of taking extra precautions. You just take your pill and catch up. On the other hand, as we all know, the pill from the outset has been bedeviled by so-called estrogen-related side effects. The mini pill, on the other hand, is also highly effective when it's used perfectly. Its principal mode of action is by changing cervical mucus and stopping sperm getting in. But in order to do that, you have to take your mini pill within a 3-hour window every day. And if you do not do that, contraceptive efficacy is lost. And of course, as many of us know from our patients or our wives, breakthrough bleeding or irregular bleeding is a common problem with the mini pill. So I'd like to introduce you to a new progestogen-only oral contraceptive. It's called Slinda, and it contains 4 milligrams of drospirenone in a 24+4 dosing regimen. So unlike the mini pill, which has progestogen in every tablet, this is more like the combined oral contraceptive with a 4-day hormone-free break every cycle. It has comparable efficacy to the combined oral contraceptives, but also like them, it has a 24-hour missed pill window. And of course, it's progestogen only, so it avoids estrogen-related risks and side effects. The drospirenone was chosen because it's quite close to progesterone in its mode of action. It's an analog of spironolactone. It suppresses ovulation, and of course it has the inherent progestogenic activity of effects on cervical mucus and the endometrium, and that's how it achieves its contraceptive efficacy. But it also has some anti-androgenic activity and some anti-mineralocorticoid activity, which improve its tolerability and its acceptability to women. But above all, of course, is that 24-hour window. That's the real thing that differentiates this progesterone-only pill from the previous groups of so-called mini pills. The 24-hour window makes all the difference. Over about 2,500 women, perhaps a little more, have been involved in clinical trials of this product, 2 trials in Europe and 1 trial in the United States. You can see there are some differences. In the American study, more women were younger. Also, you'll note in the American study, more women were not just overweight, but obese. Sadly, 35% of the women in the American study were obese. Blood pressures were pretty much the same in all groups of women. But if you look down the bottom, you can see when we look at cardiovascular risk factors, again, there was a difference. It's a little bit more than double in the American group than it was in the European group. If you're wondering what those risk factors were, mostly for the Americans, it was obesity and a sedentary lifestyle, and mostly for the Europeans, it was cigarettes. But both those trials demonstrated very effective contraceptive efficacy. In the European studies, it was 99.27% contraceptive efficacy for women who were on a large range of ages from 18 to 45. You'll see, though, in the American study, it was 97.4%. And that does seem odd, but there are a few reasons for that. Compliance is one, but another is the method by which the Europeans and the Americans measure and associate pregnancies with the trial. In the European trial, you've got 2 days from your last pill to get pregnant to be included. But in the American trial, it's 14 days from your last tablet. So that might explain the difference that we see there. But most importantly, if you look at recent trials of oral contraceptives that we know, then you can see that these values are similar in European studies and in American studies to Zoli, to Clara, to Yaz, to Yasmin, and to Nextstellis. It's a safe option. It's progestogen only, so there are no estrogen-related risks or side effects. It has a neutral effect on liver-dependent coagulation factors, and you can see that in the table on the right of this slide. And in those trials, in over 20,000 cycles, there were no cases of thromboembolic disease, stroke, or myocardial infarction. It's safe for breastfeeding mothers. The critical cutoff for drug into the breast milk is 1%, and you can see that for this preparation of drospirenone, the amount of drug which gets into the breast milk is actually 0.1%, and at that level, no effect on breastfed babies is to be expected. And it's safe for adolescents. There was also a trial on younger women done in Europe, which showed that firstly, estradiol levels remained in the mid-follicular range, which is important for their bone health in particular, but it also showed that those young women in the trial had less breakthrough bleeding, less heavy bleeding, less pain, and consumed fewer painkillers. So there are a number of positive aspects for young women as well. And we don't expect any adverse effects on bone health because of maintenance of the estradiol levels. And of course, neutral effect on laboratory parameters, no effect on body mass index or body weight, no effect on heart rate or blood pressure, a low incidence of common adverse reactions. None of these trials were placebo-controlled. They were either single-blind studies or comparator studies, but the level of adverse reaction you see there is about what you would see in a placebo group in most clinical trials. And in the comparator study, which was desogestrel pills, the acne rate was lower than in the desogestrel group. And interestingly, only 3% of women withdrew due to unscheduled bleeding. And that's a pretty impressive rate. In fact, the WHO estimates that about 25% of women who take the progestogen-only mini pills will stop because of bleeding problems. The 24+4 regimen was developed to try and establish regular withdrawal bleeds and to reduce the incidence of unscheduled bleeding or spotting. And you can see in the little table on the right, it does just that. By 6 months of treatment, about 30% of women have amenorrhea, and by 12 months of treatment, 48% of women have amenorrhea. And those who still have some bleeding or spotting will find that their bleeding or spotting is confined to less than 1 day per month. So a very big improvement in bleeding problems compared to the predecessors in the world of progestogen-only pills. There are, of course, some contraindications, the usual things. I've told you it's not associated with an increased risk in thromboembolic disease, but of course, if you had had an active thromboembolic event, you should not start the pill. Similarly with active liver disease, or of course any active cardiovascular events. Because it's a spironolactone derivative, it can, in cases of patients with renal insufficiency or renal failure, lead to a rise in potassium levels and hyperkalemia. In the clinical trials, the incidence of that was 0.5 to 1% of all women, and none of them had any symptoms. But if you are treating a patient who has suspected renal insufficiency, first of all, you may not choose to use this product, and secondly, if you do, you should monitor potassium levels for a few months. Obviously, it shouldn't be used with known or suspected sex steroid malignancies, undiagnosed PV bleeding, a known or suspected pregnancy, or hypersensitivity to any of the active ingredients in the pill. So who would you consider it for? You could certainly consider it for any woman who seeks contraception, for any woman who's looking to reduce hormone exposure, or for any woman who's looking to avoid estrogen-related risks and side effects. So if I can just summarize for you, Slind is the only progestogen-only pill with 99% contraceptive efficacy and a 24-hour missed pill window. It's more suitable than the combined oral contraceptive for a range of women, including breastfeeding mothers, women with a thromboembolic risk, particularly those who smoke or are obese or are older in age or who have hypertension. It's important to explain to our patients that bleeding decreases over time and that by 12 months, 48% of women will experience no bleeding or spotting at all. And last but not least, it's simple to use, it's easy to start, and it comes in a 24+4 dosing regimen.
Okay, so we'd like to thank Beasons as well for their support for today. Definitely wouldn't have been possible without them. So thank you for those videos. I'd now like to introduce our final speakers for this morning's session, Jerusha Sutton and Melanie Briggs from Birth Time, following the release of Birth Time, the documentary. Jerusha is a doula and birth photographer and videographer who is the co-founder and co-director of Birth Time. Melanie is a senior midwife at the Waminda South Coast Aboriginal Women's Health and Welfare Corporation. And we're really honoured to have both of them here today to explore their experiences, all that they learned. Hopefully most people have had a chance to watch Birth Time itself, and also to give us an opportunity to ask questions about what they see the future direction of birthing in Australia, and particularly birthing on country. So thank you so much for joining us. We're going to play the trailer for Birth Time for anyone that hasn't seen it. So we'll get that started and then we'll let Jerusha and Mel take over.
We have to actually dismantle the whole way we do maternity care at the moment and start again. We're building scaffolding on the top of a system which is collapsing all the time.
Around a third of women leave their birth experience describing their birth as traumatic.
They come out the other end always feeling like they have failed, that their bodies have failed them, but actually it's the system that's failing them.
No evolutionary biologist can digest the possibility that 33% of women need a cesarean section. It simply cannot be true.
What would it take for all women to emerge from their births physically well and emotionally safe?
I can't believe you gave birth to that.
We need love. Women that know their bodies.
We're just trying to change the way our women are treated. They need a voice.
Birth has been taken away from women for the same reason that so many other things have been. It's this incredible intersection of politics, medicine, culture.
When we set off on this journey, we could never have imagined the truth we know now.
The body is just such a miracle. Mother Nature is such a miracle. So
the vagina is such a miracle.
The vagina is such a miracle. Yeah.
Hi, everyone. Mel, you happy for me to go first?
Yeah. My phone is on 15%, so I apologise in advance if I drop out. I'm very sorry.
Do you want to go first, Mel?
Do I? I'm not sure. Would you like me to? Sorry.
Up to you.
Sure. No, I think you should go first.
Okay. Hi, everyone. Sorry about that. Thank you, Maddie, for that introduction. So as Maddie said, I am Jerusha Sutton. I am one of the co-founders and co-creators of Birth Time, the documentary. I am a doula. As Maddie said, I've been a doula for 15 years, and I'm sure most of you know what a doula is. It's a trained companion who offers continuous non-medical physical and emotional support to a woman and her partner before, during and after childbirth. So I have worked with women in all settings, private hospitals, public hospitals, birth centres, home births for the last 15 years. So I have the benefit of seeing birth across the spectrum, I guess. How we came about, so we are 4 women who joined forces. Myself, Jo Hunter, who is a privately practicing midwife, Zoe Naylor, who's an actress, and Selena Scoble, an Olympian come online tech guru. We came together to create a documentary, of which the trailer you've just seen, and I don't know if any of you've seen the film, and also a movement to change for the better what is going on in our country. So 5 years ago, we started with a question and decided to make a documentary with no experience, but we knew it had to be made. And the question that we asked was, what would it take for all women to emerge from their births physically well and emotionally safe? So essentially, we wanted to change the direction of the rhetoric that women hear in childbirth, which is all that matters is a healthy baby. This is what we hear time and time again. And what that means is that it completely disregards the woman's experience of birthing her baby. And so we set about changing this question, and we interviewed midwives and obstetricians and academics and doulas and doctors and women and their partners. We followed women through their birthing journeys. And we came up with some pretty astounding findings, I think. And probably the most astounding one we came across quite early on was that, according to a recent Australian study, that 1 in 3 women are coming out of their births feeling traumatised. So that 1/3 of women in this country are feeling traumatised from their birth experience. Now, of that 1/3 of women, 2/3 of those, their trauma comes from care provider actions and interactions. So it is what is being said and done to them during their births that is giving them the trauma. So this is clearly, so far from what we need it to be, because, if women we know a birth is the launch pad into mothering a baby, and if women are going into their mothering with trauma, then things are very off. Another statistic that we heard was that our caesarean rate, when we started filming 5 years ago, was 33% in this country. It has since, in the last 5 years, risen to around 35, 36%. Now, the World Health Organization say that 10 to 15% caesarean section rate is what benefits mothers and babies, and anything above that is excessive. So we are more than double that at this point in time. We know that interventions are at an all-time high, and we also know that postnatal depression is at an all-time high in our mothers. So all of these statistics and facts and information, this is what we formulated our film around these facts, and then looking at what we can do to change that for our women, to make things better. And this is a bit of a spoiler alert, I think, for anyone who hasn't seen it. But what we came across from all the academics and midwives and doctors we spoke to was them all saying that across the world, all of the top level evidence states that relationship-based care is what gives women and babies better outcomes. So one-to-one midwifery care becomes the gold standard of maternity care in our country, where women have a named midwife that they have a relationship with to take them through their entire journey. And then relationship-based care then extends on to women who do need obstetric care. The relationships go throughout. So the woman having a relationship with any obstetricians or any other clinicians that she needs assistance from, and also the midwives and the obstetricians having relationships with each other so that everyone is working congruously to do the best for the woman, and essentially putting the woman back at the centre of the care, putting the woman as the expert. We have to remember that women are the experts of their own bodies. So her team is about giving her information, giving her unbiased information, and letting her make decisions and giving consent in a way where she is not fearful of being judged, where she is not coerced, where everything that is presented to her is factual and non-judgmental. So this is essentially, I guess, you know, what our vision is for greater outcomes for women and babies. Now, we interviewed several amazing obstetricians in our film, and we asked them lots of questions about what the current challenges in obstetric care are, and why we've reached a point in obstetrics where our interventions are largely being overused. And the obstetricians were saying this themselves. It's not us putting, you know, that on them. And they talked a lot and very openly about the overriding system and how the structure is quite oppressive and how the fear of litigation can play into decision-making very powerfully. And one of the most astounding things that I think we heard from an obstetrician is that, and this is an obstetrician who works in academia and teaches in universities, she says it's very common for student doctors and obstetricians to make it through their entire training having never seen a true physiological birth. So never having sat in a room and watched a woman with a labour that starts spontaneously, that is not augmented in any way at any point, that needs no help with instruments or anything for the birth of her baby, needs no help to even birth her placenta. There's no Cinto, there's no nothing, that a woman in her power birthing her baby without any need for medical help. And I would be very interested to hear from all of you whether this is the case, but this is what we're hearing, is that doctors are not being exposed to this. And so when we question why interventions are at an all-time high, it then becomes evident that the people who are giving the care, if they haven't seen how physiological birth works, then why would you have any trust in it? Yes, interventions are absolutely needed. We need them for safety. We need cesarean sections. They're absolutely life-saving. We just wanted to explore how we can use them more appropriately and make these conditions better for women. So that was a really big penny drop moment for us. So on that front, if I could encourage one thing, it would be, when you can, however you can, find a room, get permission first from the woman, but find a woman giving birth without any intervention and go and sit in the room, sit on your hands and be silent and watch in awe as it unfolds, because what you will witness is you will never go back from that. It is an astounding thing, and it's the only way I think we can learn about how physiological birth works and how actually brilliant it is. Now, one other thing I wanted to say was that I'm sure a lot of you are familiar with the work of Dr. Andrew Bissett's at the Royal Hospital for Women in Randwick, and if you're not, seek it out. I've worked alongside Andrew many times with clients who have, in my role as a doula, who have come, women who've hit various complications. He is the doctor that women seek out when other doctors say no, and not because he's a cowboy, I think, because his skill set is such that he does trust that process and he listens to what women want. We recently posted a flashback of interviewing Andrew Bissett's on our social media, and we got so many comments from women saying how he helped them, but we got one message which really struck me, and I wanted to share this with you. A woman wrote to us and said, "This beautiful man helped me deliver my baby when he was in a less than ideal position. Other obstetricians failed, but Dr. Bissett's did it in one go. He was so respectful and calm, and despite needing forceps, he got me to push out my baby once he was in the right position. The best part was the next day he visited my room and he sat in the chair beside me and he asked me how I felt. He asked me if I wanted to debrief what had happened, if I had any questions, and he stressed the importance of looking after my pelvic floor and attending physio. I felt heard, respected, and safe. I am so grateful that the interventions that I had were by this lovely human. So if I can implore you to take away one key message from this, it would be to put the woman and her experience at the centre of your care. Give her choices and listen to her. Seek true consent and to do any procedures you may need to do. And if things don't go the way she hoped afterwards, go and sit by her bed and ask her how she feels and truly listen to her, because you could change the way that she sees this birth for the rest of her life. So if you haven't seen the film already, it's streaming from our website, birthtime.world. And also we have created an online hub where we have the entire interviews, full-length interviews of all of our experts that you can subscribe to and take in all of those interviews in full. They're like a masterclass. And so I want to hand over to Mel now, who plays a beautiful part in our film and in a section dedicated to birthing on country. Thank you.
Thank you, Roo. That was very lovely. So before I start, I'd just like to acknowledge the traditional custodians of the land in which I'm talking to you on, which is Yuin country, and pay my respects to my elders, those that have passed and those that are present and continue to support me each and every day in my role. I'm an Aboriginal woman. I am a descendant of the Gumbaynggirr and Dharawal peoples and live on Yuin country in Nowra, New South Wales. I'm an endorsed midwife and work for an organisation named WAMINDA at South Coast Women's Health and Welfare Aboriginal Corporation. We are based in Nowra and provide social, we're a social model of health. And so birthing on country came into to WAMINDA in 2017, but prior to that, you know, our women have been birthing on country since prior colonisation. So our methods, our practices, our laws have been practiced on country since before 230 years ago. So this is not new to our people or to our women. And I guess birthing on country is, it's described as an international movement with the overarching aim of returning birthing services to Indigenous communities and Indigenous control to enable a healthy start to life. The agenda for birthing on country relates to a system-wide reform and is perceived as an important opportunity in closing the gap between Indigenous and non-Indigenous health and quality of life outcomes. The history is 2012, the Australian Maternity Services Interjurisdictional Committee, in collaboration with the Central Australian Aboriginal Congress, held the first National Birthing on Country workshop to progress the Australian government to commit to a birthing on country program. People gathered from all across Australia with a strong Indigenous presence to discuss birthing on country and determine the next steps. So part of WAMINDA's role and my role for birthing on country is being an Aboriginal midwife, working in my community, caring for my mob and making sure that women receive the best cultural and clinical care possible to ensure these women have the best possible outcomes for their pregnancies and their newborn babies. So when we talk about the best start in life, what does that actually mean? It means that women feel respected, they feel heard, they feel validated. Everything Jerusha just said about woman-centered care, known carer, and all of those important things, it also needs to ensure that our women are cared for in a culturally safe way. So what is cultural safety? It's about having cultural integrity, having awareness of who your local people, Aboriginal people are on the country that you're working in or on, and ensuring that women feel care, and if women feel safe and feel heard, they will attend appointments and they will build professional relationships, safe, respectful relationships with you. And it's all about, being human and sitting down, exactly what Jerusha was saying about Dr. Bissett's, sitting down and just being, just listen, and you will gain the respect of women, especially Aboriginal women. They want to feel heard and they want to feel respected. So I guess, being an Aboriginal midwife, I'm led by my elders in my community. They give me my knowledge and my strength, and they also tell me what I'm doing right and what I'm doing wrong, which is very important, because when it comes to women's business, it's very sacred. So, we've been on this journey now since 2017, and our plan for Waminda is to, so if you look at Professor Sue Kilday, she's researched this since its fruition back in 2000. Well, it's been over 20 years since Sue has commenced the research for this, but she's also designed a framework with other professors such as Yvette Rowe, Juanita Sherwood. It's called the RISE framework. There is a publication on it, and it's around redesigning mainstream maternity care to adapt and change to culturally safe maternity care for Aboriginal and Torres Strait Islander women in the country. And it actually, so R is for redesigning, I is for investing workforce for Aboriginal and Torres Strait Islander midwives, and the S is for strengthening communities. So, having that wraparound support services so that we as midwives can provide clinical care and then be supported by social and emotional workers, such as caseworkers, drug and alcohol workers, mental health, all of those things that impact women's ability to access services. We're supported by our social work teams as well. So that's the strengthening communities, and women feel empowered by that because we're their vessel to enable their decisions. They make the decisions, we enable access. So that's, and we build those relationships with the women. And then there's embedded governance. So what that means is that a birthing on country model of care cannot be, it needs to be owned and governed by the Aboriginal people. It needs to be led by Aboriginal people. It needs to be women birthing in their own community and, claiming their sovereign right to our lands. So it's about taking it back, reclaiming and reviving our cultural law and women's business. And that framework, you should be able to look that up, or I'm happy to share it if anyone would like me to share that publication about the RISE framework and how it changes in phases. So, the National Health and Medical Research Grant, in which Birthing on Country is that it includes 4 different sites. So there's an urban site, regional site, and remote and very remote. So that's Brisbane, Nowra, Alice Springs and Gallowinku. So there's still lots of research happening in Gallowinku and Alice Springs as well. So we're still moving forward at Waminda, and what we're aiming to do is have a purpose-built birthing centre so that our women can receive all of their care through the birth centre, and if they can't birth at the birth centre, then we support them to birth at the hospital, but we're their primary midwife at the hospital. So that's where we're aiming to be in the next couple of years. So it's happening. It's very slow. There's a lot of things to change, but we're getting there. So yeah, that's me. And if there's anything that that you would like to follow or know a bit more about Birthing on Country, you can look at www.birthingoncountry.com. You can look at WAMINDA, waminda.org.au. You can also Molly Wadaguga, and all of the information regarding Birthing on Country is, thank you, Katie. All the information regarding Birthing on Country can also be found on WAMINDA's Birthing on Country tab. So if you click on there, it'll take you to Molly and Birthing on Country. So, yeah, thank you.
Thank you so much, Jerusha and Mel. That was, yeah, amazing to hear from both of you. And I can very much relate to the quote initially with the birth time documentary, that 1 minute you'll be laughing and the next minute you'll be in tears, and definitely inspired some very deep thinking, I think, for most of us who are working in the public hospital systems and looking at the system and model of care that we're currently providing for women, and where we can, you know, look to improve and how to go about improving that. So I'd welcome people to send through some questions if they have any. I might start off with a question of my own, which is just about whether, following the release of Birth Time documentary, whether you've had engagement from hospital organisers or the people involved in these structures in, I guess, advising on restructuring these to better perform that women-focused care.
Yeah, we absolutely have. We are in contact with a couple of hospitals. We were, even before the release of the film, we worked quite closely with Westmead Public Hospital. I mean, we profiled them in the film. They got us in for a Q&A a couple of years before the film was even released, to speak with their staff there, which was great. They held a Q&A night. We also record live events, and so we have events like Human Rights and Feminism in Childbirth with Hannah Darlin and Bashi Hazard. So they hosted a night screening that event, and we're also in contact with a couple of other hospitals about who are very keen to restructure and get rid of the bullying and get rid of, you know, that even the care provider, you know, it's not just the women and the families who are being bullied, it is the bullying within the staff that they want to change, and they want to start, you know, people congruously working together to make it a better workplace environment. Because if everyone's more happy and supported and unjudged in their workplace, then that then feeds onto the women. So I think it's Deborah Pascali-Bonara in the film says, you know, if the abuse just filters down. If our doctors and our midwives are being abused from above, then they pass that on. That's just how abuse works. So yeah, we are working with a couple of hospitals on that proudly.
That's really exciting to hear. Yeah, I think we can all relate to probably having some really positive experiences with good units that have a good vibe, and then negative experiences and seeing the impacts of that. So it's really exciting that people are engaging with that. There's a couple of questions on the Q&A, Jerusha, I'm not sure if you can see that. The first one is directed towards you, and it initially thanks you for advocating for such an important issue in childbirth and obstetrics. The question is, do you feel that suboptimal antenatal education, social media and expectations have set up women for a negative experience? And if so, how can we navigate and improve this as healthcare practitioners?
Look, you know, education absolutely needs to be optimal. You know, education, knowledge is power. And so, you know, way back, you know, women used to be able to just go into their birth with not much knowledge because they were surrounded by a supportive network that held them and knew how physiological birth worked. And now it's like women need to go, they need to educate themselves to everything that might happen, because the options of what might happen are so vast now that we are testing and monitoring and doing all of the things. You know, it's like a PhD that you need to get while you're pregnant to be able to go, especially into a hospital, to give birth. I think saying that it's setting women up for unrealistic expectations undermines what physiological birth can actually be, you know. And I think what we need to focus on is setting the bar higher so that women can reach the births that they want. You know, I know there's, in a lot of medical kind of frameworks, they say, oh, bring us your birth pain so we can have a laugh. It's so disrespectful to come at that. You know, yes, we can't plan for birth, and yes, things do go in different directions, but there's no way we can plan it. But don't disrespect women for knowing what they want in an ideal circumstance and helping them achieve as close to that as possible. And then, as I, you know, helping them debrief and acknowledging that if it doesn't happen. So I think we actually need to set up our structures so women are not being disappointed. We need to set them up to win.
Yeah, absolutely. And I think there's a great example of that within the documentary, a particular woman who has had a negative experience and goes back with a plan, and, you know, we get to follow her through. I won't ruin it for everyone, but it's a very poignant example, I think, with this question. So would very much encourage people to watch it after this. There's another question related to antenatal education. So the question is, they believe that unbiased information is essential for decision-making in birthing people, and they feel that antenatal education could and often does play a pivotal role here. However, the antenatal education at the moment is not universally accessible or comprehensive, meaning a lot of this information is not necessarily getting to women before they need to make those decisions in sort of the setting of labour, with all of the emotions and I guess, you know, sometimes chaos that's happening around that. What do you think is the role of antenatal education here, and how could it be improved, and who should be responsible for this? I guess also, Melanie, we might be able to get your insights here from within your service.
Mel, why don't you speak to that?
Yeah, sure. Look, I think what's really important here is that we all share the same knowledge and that we all respect each other's professions, because what we do as midwives, we work with women, we inform women of their choices as much as we possibly can. And also, it's also about accessibility and service delivery and service availability, because when you look at women that live in regional and rural and remote and very remote areas, they don't have continuity of care. So how are they going to get, you know, all the latest information around antenatal education? I don't think it's targeted to one specific profession. I think all women and all health professionals working with birthing people need to understand that we have to work together to ensure that you know, women know what services are available in their area. So they could have private midwives, they could have midwifery teams, they could have publicly funded midwifery, but every area is different, and we cannot blame one place or one service or one profession for the lack of antenatal education. It's just not fair. I think what we need to do as a maternity team, which is midwives and obstetricians, is that we need to share the information together. We need to make plans together, because like Jerusha said, like we have women that are unwell and that need to be able to be supported by obstetricians. But if we collaborate and talk together and plan together the care for these women, then women will feel nurtured and supported. It's all about what we provide to the women as a team. And it's not always just singular one person or one profession that should be targeted. Antenatal care is all of our responsibility, not just midwives or doulas or birth people, or it's everybody's. So I think we need to share that responsibility of antenatal education to ensure women feel safe and supported.
Absolutely.
Did that answer the question?
The next question is along a sort of a similar line, but we'll see if you've got any further insights. How can we strike a balance between aiming to minimise interventions and potentially the resultant woman's shame/self-blame when interventions are performed?
Okay, I'll go. Look, you know, there's so much to that, but like the previous question, it is about antenatal education. And so women in labour is not a time to be learning about birth. It's not a time to be learning about interventions and why things might be happening to you. It's also not a time for a woman to be, or a birthing person to be, in battle. Women shouldn't be going into their birth feeling like they need to fend things off from the off. You know, they need to go in and they need to be vulnerable and they need to be open and they need to be held in a safe space where they feel like they trust everyone around them. So that's the first step, is creating a space for them. That's where we're minimizing interventions. You know, even things down to hospitals providing things like birthing pools for women to be able to, you know, for pain relief. And so we're setting them up to win. We're setting them up in rooms that are comfortable, where they can get on the floor, with doctors and midwives who are comfortable to get on the floor with them, that aren't putting them on a bed and aren't constricting them with monitors all the time. And, you know, so it's looking at all of those factors, because all of that, when a woman is trying to get into her primal brain to birth her baby and there's things going bing in every corner of the room, then it, you know, and people monitoring her and strangers coming in and out. It's like trying to take a poo and people walking in and out of the toilet. Like, it just doesn't work. So we need to really look at how we're caring for women to set them up for the best. And then when interventions do happen, again, I think it comes down to relationships, and it comes down to communication. If a woman has a relationship with a care provider that she trusts, and so that she knows if she needs interventions that they were needed, that they were necessary, then she may be disappointed, but she won't be traumatized. And there is a vast difference in that. If she's been given the opportunity to debrief what happened and she knows exactly why things happened, and she was given the choice during the process, not told what she was doing, if she was given time and she was respected in her decisions. And one of the key things in that is, apart from in really acute emergencies, is giving a woman time to adjust her thinking, to adjust, you know, her expectations of what's about to happen, giving her some space, stepping out of the room and letting her and her partner and her team talk about what might be happening, to let that sink in before it happens. It makes the world of difference. So I think, you know, again, relationships and information, preparation, and then relationships and debriefing. It shifts it. You know, women will still be disappointed, but the disappointment doesn't need to be trauma.
Can I just add to that, please? Can I just add to that? We have to trust women. We have to trust their decisions, that they know their bodies better than we do. We have to trust and listen. Like that's what we're there for. The fear of litigation, that's our fear, and we're putting that fear onto other people making decisions about what they already know, you know, what they know, that they feel okay. I think we need to trust. There's a big lack of trust there, and we just need to sometimes just let go of our fears and trust others and people birthing.
Absolutely. We might make this the last question because we are running out of time. But from both of you, with your experience as a doula, Jerusha, and also Mel, your experience setting up a whole new service, what have you seen as the best way to bridge that sort of gap that's sometimes there between the different members of a woman's team when she's coming into her birth, or I guess antenatally as well?
I think it's remembering that everyone there is space for everyone in that team. If everyone there is needed, then everyone has different roles. You know, when I go as a doula into a hospital, I'm not there to step on anyone's toes. I'm not there to do an obstetrician's job. Of course I'm not. And I know, you know, and I'm sure this is no surprise that over the years, I mean, it has changed over time and experience, but often I would walk into a hospital and feel, you know, people won't even give me eye contact because they feel like I'm there to, you know, step on their toes or to change the woman's perspective or to try and boss people around. It's not like that. Forever I am saying we are all here together to make this woman's experience as positive and supported as it can be. And so a doula's experience, a midwife's experience, and an obstetrician's experience all have space in that room. And I think it's respecting the difference in the roles. You know, an obstetrician isn't going to be there through the night doing compressions on your lower back for 8 hours. They're not. That's what a doula's, you know, that's what a doula does. And that's often what a midwife does. If there's not a doula there, they're not going to do that. I'm not going to be going and assessing, you know, their fetal heart monitoring or their, you know, anything, making decisions about forceps and von tooth. I'm not going to be doing that. So I think it's communication, and I think trying to level it out, get rid of the status. Everyone work together. If a midwife's been in a room with a woman for 4 hours, then talk to her about what's going on with the woman. Don't look at a machine out in the hall and then come in thinking you know what's going on with this woman. You need to, it's communication with everyone, including the woman. Mel?
Yes, 100%, Ruth. Communication is key. Like you talk about, I think I was actually at an MGP conference and Dr. Bissett was on the panel and he talked about collaboration. And what is collaboration? He said, well, collaboration is sitting down at the table with people that you work with at a dinner table, having dinner together and having a yarn, knowing what each other's strengths are and knowing what each other's weaknesses are and being able to turn on your mate and rely on them because they know your weaknesses and your strengths. And when you're working in that team, you can just bounce off one another and you know that person's got your back. That's true collaboration, and that's what Dr. Bissett said on that panel that day, and I've never forgotten it because, we've got our little team that we work in, and I know when I don't know something, which is a lot of the time, I'll ask the girls, what does this mean? What do we do about it? And that's not a weakness, that's actually a strength, is asking for advice. Because we don't know everything and we're silly if we think we do, because not everybody knows everything. And I think knowing what you know is great, and being good and strong at that is your power. Everybody has their power, and having power is also acknowledging that you don't know. So that's one thing that about this communication and this collaboration is that we can all work together. We all know what we're good at. We all know what we're not good at. Let's just stick with that and work as a team. That's what I think.
A very important message to finish off today. I can't thank you both enough for joining us, not only just for joining us today, but also for all of the work that you've been doing. And we really can't wait to see all of the amazing effects this hopefully has going forward, and hopefully everyone's inspired to try and support those changes and advocate for women-centred care going forward. So thank you both so much again. And I'll hand over to Katie to close this morning's part of the conference.
Thank you.
Thanks, Maddie.
Bye.
Thank you, Maddie. What a wonderful morning we've had. I started the day with Professor Roach saying that we shouldn't be losing sight of words like fun and joy. And I have taken a lot of joy out of this morning, seeing the evidence of passion of all of our speakers. I think the key message that Jerusha and Mel shared, but also was apparent in various different ways throughout everyone's speech this morning, was that we all should be focused on giving power to the woman. And I hope that you all have something that you can take away into your workplace to give that power back to our patients. I just want to briefly touch on, before we close today, the 2022 PVOGS selection process. We are very, very excited to invite you all to apply for the 2022 PVOGS committee, both the Australian-New Zealand Executive Committee as well as the state and New Zealand-based committees as well. This will be opening up tomorrow, and there'll be information posted on every of the Facebook pages. So I do encourage you to follow both the ANZ and your local Facebook page. This year, we've decided to do a centralised application process as part of our transitioning to the new company, which means you'll only need to complete one application form to apply for both your local areas committee as well as our ANZ Executive Committee. And so the applications will be open for 2 weeks if you're applying for the executive or the chair position in your local area, and 4 weeks if you're applying for other positions within those regional committees. We really hope to see a lot of you getting involved in that selection process. I'm going to hand over to Jess to close us off.
Thanks, Katie. Just wanted to say again, thank you to our lovely team for organising such a fantastic conference. And thank you to you all for attending and being able to join us on this fine Saturday. We hope to see you at future events, and please don't forget to like your regional PVOGS Facebook pages, particularly the New South Wales group, which has just been reinstated, to keep in the loop about future events. And thanks again to our wonderful speakers who made this what it was able to be. Thank you all, and enjoy the rest of your day.